Hi, I'm Susan Taylor with Scripps Health in San Diego, California. IBD, inflammatory bowel disease. Sounds kind of yucky. It is. It causes long-term inflammation of the digestive tract and can lead to persistent and severe diarrhea, abdominal pain, unintended weight loss, and other symptoms. According to the Centers for Disease Control and Prevention, roughly 1.6 million people in the U.S. suffer from IBD. It is chronic, but there are ways to treat it. Joining us today is Dr. Gori Konijetti. She's a gastroenterologist who specializes in inflammatory bowel disease, including Crohn's disease and ulcerative colitis. She's head of the Scripps Clinic Inflammatory Bowel Disease Program in La Jolla, California. Thanks so much for being with us.
Thank you.
Let's start with the basics. What is inflammatory bowel disease?
It's exactly like you just described. It's chronic inflammation of the GI tract. The two most common types of inflammatory bowel disease are Crohn's disease and ulcerative colitis.
And how common is IBD?
It's not that common. Like you said, it affects about 1.6 million Americans, over 2 million Europeans, but we are seeing it increasing in developing countries.
And what are the symptoms of it?
The most common symptoms of inflammatory bowel disease are symptoms like abdominal pain, diarrhea, it can be bloody or non-bloody, and rectal bleeding, so bleeding coming out from below.
And is this just like a sudden onset of all of these together, or they might come one at a time?
Yeah, so it's different for every patient. So for some people it just starts sort of full blown, and for others it kind of starts small and mild and they may not even realize what's going on, but then it gradually progresses.
And who's at risk for getting this?
You know, it is more common among Caucasians, Ashkenazi Jews, but like I said, we are seeing it increasing in developing countries as well.
And what about age? What's the onset of it?
So it can affect anywhere from babies to the elderly.
Really?
But the most common folks affected are people in their 20s to 30s. And then with ulcerative colitis, we also see sort of a second peak in the 60s to 70s.
And more men than women affected, women than men?
For Crohn's disease, more women than men. For ulcerative colitis, we see a relatively similar distribution.
So you talk about the two types, Crohn's disease and ulcerative colitis. Why don't you explain what those two are?
Sure. So they're both chronic inflammatory diseases of the GI tract. Crohn's disease can affect any part of the GI tract from the mouth all the way down to the anus, but it most commonly affects the colon as well as the end part of the small intestine that's connected to the colon called the ileum. Ulcerative colitis is really just limited to the colon. I guess a couple of other nuances. So Crohn's disease can affect all 4 layers of the GI tract. So, it's a long tube that goes from the mouth down to the anus. And ulcerative colitis is really limited to the innermost lining of the GI tract. The only reason I highlight those is just because it can affect the symptoms that people develop and even the complications that can develop from ongoing inflammation.
So we talked about the symptoms before, and people can have abdominal pain and people can have diarrhea. So we want you to hold this thought for a second. We're going to come back and talk to it. When you have these symptoms, when should you take this seriously and say, actually, I really need to go see a doctor to check that out? Okay. So are there ways, so inflammatory bowel disease, it cannot be cured, correct?
It can't be. The mainstay of disease management is really control of the inflammation. I would say, though, that there are some patients where it does seem to just sort of go away or even just become quiescent. But that's
so it can go into remission?
It can go into remission, really? But that's in the minority. Most people do require some form of medication and management to keep the disease under control.
Is there something that triggers it?
Yeah, there are a lot of triggers. So there are a lot of environmental factors. For example, whether or not you were breastfed as an infant, whether or not you had a lot of infections or antibiotic exposure, things like physical activity, diet, sleep. All of those are potential environmental risk factors for developing inflammatory bowel disease. We also know that genetics plays an important role. There are over 200 genes that have been identified as being associated with IBD. Now, none of those are sufficient to cause the disease by themselves, but we do know that they play a role. And then finally, the microbiome, the bugs in our gut, those definitely play a role, although I think more and more research is trying to figure out how.
When you say whether you were breastfed or not, is there a lower incidence of inflammatory bowel disease for people who were breastfed?
Yeah, and in particular nursed. But if a child was nursed as an infant, then they have about a 30 to 40% lower risk of developing inflammatory bowel disease later on.
Another reason to breastfeed your baby.
Yeah.
For how long after you give birth?
I think in general, we usually say about 6 months. That seems to be the average recommendation.
So inflammatory bowel disease cannot be cured. Are there ways to prevent it?
Really just, I think, a healthy lifestyle, and trying to minimize unnecessary exposure. So on the healthy lifestyle, really eating a nutrient-dense diet, high in fruits, vegetables, fish, and fiber. I would say making sure that your vitamin levels are good, making sure that you have adequate vitamin D and zinc. Getting enough sleep, getting enough exercise, and then things like minimizing exposure to ibuprofen or naproxen or other NSAIDs that are associated with an increased risk of developing the disease, avoiding unnecessary antibiotic exposure. All of those are just generally good, probably for preventing a lot of conditions in general.
All right, so let's talk about the treatment of inflammatory bowel disease, because I know there's different stages of treatment. So what do you start off with?
Oh, that's a great question. So, figuring out what treatment to put a given patient on really depends on what's going on right now. So how active is their disease? How severe is it? But then also, what is their chance for developing complications down the road? So, we kind of have to look at what's going on now, maybe what's also happened in the past. Have they needed a lot of steroids, surgeries, hospitalizations, and then what is their chance for developing complications in the future? We take all of this information, put it together, and then think about the best way to approach. For some people who have more mild disease, I think we can start out with non-immunosuppressive medications, so sort of anti-inflammatories for the gut. Whereas for people who do have much more active disease, maybe they're hospitalized, maybe they're at high risk for developing complications, we tend to start out with more of our targeted immunosuppressives that are directly targeting the pathways to treat inflammatory bowel disease.
What do you mean by immunosuppressive?
So we have a variety of classes of medications. We have biologic medications, which you probably heard about. Those are antibody-based drugs. We also have oral immunosuppressives as well.
So how do you treat inflammatory bowel disease? Because there's different stages of treatment. First is prescription drugs, correct?
Right. So we take an assessment of the patient. We look at what their clinical history has been up to the time they've met us. How many times have they needed steroids for their disease? How many times have they been hospitalized? Have they needed surgery? And then we look at what's going on now. Do they have more mild disease, or is it more moderate to severe, where we're really worried, that they're not going to be able to sustain this level of disease activity, and we need to get it under control much more quickly. And then finally, we look at their risk of complications down the road. We really want to minimize the chance that they'll develop issues that might require surgery or hospitalization. As far as treatment, once we determine where they stand as far as what's going on now and what their chance of complications are, we talk about treatment. If they're on the milder spectrum, particularly for ulcerative colitis, we think about a drug class called mesalamines. These are what I think of as sort of topical anti-inflammatories for the gut, and patients can take them by mouth, or we have various formulations that we can actually give from below through the rectum. For more moderate to severe patients, we do have other options for therapy. We think about biologics, which are antibody-based drugs. So these include medications such as infliximab, adalimumab. You may have also heard about ustekinumab, which is recently approved, as well as vedolizumab. Those are some of the common biologics we use. We also use oral medications, particularly tofacitinib, which was just approved as well. And then, there are other medications that we use either in combination with these or as solo medications, sometimes if it's not quite so severe. For steroids, we do use those a fair amount, but we really try to minimize exposure and just give it really when needed. They're considered more of a bridge to therapy and to really help quiet down symptoms. They're not intended for chronic or long-term use.
And if medication doesn't work, there are options with regard to surgery. Why don't you talk about those?
Yeah, so the surgical options are a little bit different if you have Crohn's disease or if you have ulcerative colitis. So we'll start with ulcerative colitis. If patients have significant severe disease, or they're not responding to therapy, or they develop precancerous lesions of the colon that can't be removed, then we do think about having their colons removed. And we do think about that as being curative. So a patient can have their colon removed, and then that results in altered anatomy. They may end up with an ostomy, which is basically a connection of their gut to their skin, and then they wear a bag. Or they might end up with something called a J pouch. A J pouch is where they take out the colon, and then take the small intestine, move it down, and connect it to the anus, and create a J configuration with that small intestine to create a reservoir for stool. So that's ulcerative colitis. Crohn's disease, the surgeries are a little bit different. In Crohn's disease, unfortunately, surgery is not curative. We do know that even if patients have surgery for Crohn's, that it almost inevitably recurs. Either at the connection or even just above that connection. So even though it can certainly help with a lot of the complications, it doesn't. And those surgeries are really centered around what's going on. So if a patient develops a narrowing, if they develop a fistula, which is a connection from one part of the bowel to either another part of the bowel or another organ or the skin, those often require. So it really just depends.
Now the surgery, this sounds, when you talk about, having to have a bag where your stool would come out, that's obviously a major change in your lifestyle.
It is.
But what happens if you don't treat inflammatory bowel disease?
If you don't treat inflammatory bowel disease, then most people do develop or are at risk for developing complications. So they're in Crohn's, for example, they're at risk for developing those narrowings, those sort of fixed scars that are really difficult to overcome with any treatment. They can develop the fistulas, and what happens is those end up significantly affecting their quality of life. They often require more aggressive medication, and patients tend to have a poor quality of life because they're much more symptomatic.
Can it be life-threatening too?
Potentially, yeah, especially when ongoing untreated disease results in chronic steroid use or infection or other complications.
Does having inflammatory bowel disease, does it put you at higher risk of getting colon cancer?
It does. When I was in training, we used to look at the statistics and say, we usually think about the risk of colon cancer going up about 8 years after someone has started having symptoms of inflammatory bowel disease. And we used to say, about 10% at 10 years, 20% at 20 years. Recent estimates suggest that those risks are lower, but certainly higher than in the general population. So for that reason, we actually start screening patients with Crohn's disease and ulcerative colitis earlier and also more frequently.
So this is a chronic condition. Mm-hmm. You can take drugs or have the surgery to treat it and deal with it. But you reference periods of remission. What would cause somebody to go into remission?
The most common reason to go into remission would be medication. Only a very small minority of patients ever experience remission without any form of therapy. And the goal is really twofold. One is something called clinical remission, where patients are feeling well. They continue to feel well and they're not requiring steroids. The other is something called mucosal healing, where, when we put a camera in or we look with imaging, that the amount of inflammation and ulceration in their gut is really gone. What we do know sometimes is that even when people are feeling fine, they can still have ongoing sort of smoldering inflammation in the GI tract. So that's the reason we want to accomplish both, clinical remission as well as mucosal.
So we talked about the symptoms before, and people will have these symptoms. You'll have, loose stools, you'll have abdominal pain for a whole host of reasons.
Right.
When should people actually pay attention to these symptoms and say, I really need to go see a doctor about this?
Great question. Yeah. So, whenever patients are having symptoms that are just persisting, they're not going away, or, they're getting worse. And certainly symptoms such as bleeding from the rectum or seeing blood in your stools, having really severe pain, losing weight, having to get up in the middle of the night to have a bowel movement, having fevers or night sweats, none of those are expected or should be tolerated. And certainly folks should see their doctor.
So it persists for what, a week, 2 weeks, a month?
I would say any more than a week. Yeah, it's good to get evaluated. Sometimes bugs in the GI tract or certain things that you might pick up on a vacation can last for a week. But, if you're not getting better, just go see your doctor. It's always better to get checked.
Technology has made great strides in the last 20, 30 years. Yeah. The advancements in this area, what kind of treatments are available today that were not available 20 years ago?
Oh my gosh, everything.
Everything.
Everything, yeah. It's amazing how much has changed over the past 20 years. I would say, before 20 years ago, we really just had steroids, thiopurines, methotrexate, and mesalamines. And those, while they're effective, are not as effective really for moderate to severe disease. So it's amazing the number of therapies we have that have been able to really help patients get their disease under control.
You talked about having the surgery and having the bag, the pouch, or what are the risks to this? Are there any risks to this?
Of having a pouch, or of having a bag.
Or the bag, yeah.
Yeah, so there are risks. Some of those risks are related to the surgical procedure themselves. So what normally happens is you have part of your intestine that's just pulled out through the skin. They make a tiny little stoma, so you see a small little opening, and then they would put a bag over that. And that's most commonly...
What do you mean by stoma?
A stoma is a little portion of either their colon or their small intestine that's brought out to the skin and then attached to the skin as a connection. And so you can imagine with any sort of connection, things can get loose, things can get pulled back, things can get infected. So there are risks, but generally, people who end up needing what we call ostomies sometimes wonder why they didn't do it sooner, especially when they're dealing with chronic and fairly severe disease activity.
Dr. Konajeda, you also guide women who have IBD, who need help actually planning pregnancy and who are nursing, which all sounds incredibly complicated with IBD. So how do you talk about their specific needs?
Yeah, I think seeing that population gives me a lot of joy, especially when we are able to help them get pregnant and stay pregnant and have healthy babies. And so that's always a privilege on our end. What I'd like to tell women is that the best way to increase your chances of conception, as well as have a good pregnancy, a healthy baby, is really to try and get your inflammatory bowel disease under control before you get pregnant. If you can do that, then you're much more likely to have your IBD stay in control during the pregnancy. It's always good to meet with your gastroenterologist just to check for any vitamin deficiencies that you might have before conception, because you wouldn't want to go into pregnancy with those deficiencies and then have that potentially impact how you do or how the baby does. Last thing that I would say is pelvic surgery. So having a prior history of surgery in the belly does increase the chance of not being able to conceive. But women are still able to conceive that way, or naturally, as well as even through IVF. The success rates for in vitro fertilization among women with inflammatory bowel disease who have had surgery, even who haven't had surgery, are comparable actually to those who don't have inflammatory bowel disease.
Are there clinical trials at Scripps for this condition, for IBD?
We have done some clinical trials. One of my interests is actually looking at dietary interventions for inflammatory bowel disease, and how we can use diet or other potential triggers of inflammation to reduce the inflammation itself, rather than sort of always focusing on the pathways of inflammation with drugs. And we have done clinical trials looking at the efficacy of various diets to help control the disease. So we're looking forward to doing more.
So the bottom line, if somebody thinks that they have this, or if someone is diagnosed with IBD, what are your thoughts?
If someone thinks they have this or they've been diagnosed, the best is to establish care with a gastroenterologist, who can help manage them, who can help educate them about what this condition is, what it means. We have a lot of local support groups, especially through the Crohn's and Colitis Foundation. For those patients who might need surgery or who have ostomies or might need one, we have excellent colorectal surgeons and ostomy nurses who can help guide them through that. But most importantly, just establish care with your physician.
Any final thought?
No, it's been an honor to be here, and I appreciate you having me.
Thanks so much. We appreciate it. Scripps is ranked #1 in San Diego and among the nation's best by U.S. News & World Report in gastroenterology and GI surgery. If you'd like more information on inflammatory bowel disease, just click on the link or go to scripps.org/videos. If you want more critical information about your health, we take care of you from head to toe. Please subscribe to our Scripps Health YouTube channel and follow us on social media at Scripps Health. I'm Susan Taylor. Thanks so much for joining us. It's our mission at Scripps to help you heal enhance, even save your life.